This episode of the Bari Chronicles is proudly brought to you by Bariatric Support Australia.
Hi everyone, we are here today with Dr. Alex Craven. Dr. Alex, thank you so much for joining us.
Absolute pleasure. Pleasure to be here. Pleasure to continue a conversation we've been having in and out
Yeah,
of various
definitely.
forums for a while now.
Because we could all talk underwater, couldn't we?
Absolutely. Yes. Yeah. None of us shy coming
Yep.
forward, which is good.
A couple of weeks ago, we interviewed a colleague of yours, Jared. What an amazing interview that was.
That was awesome.
You got a real life superhero there. Yeah, she's phenomenal. Yeah.
Yeah.
Jeez.
One of the things that came from that, and I was really excited when I got a message from one of our listeners, and I'm just going to share the message. Okay, so this message came from Jenny, and she's given us permission to use it. And she said, "Hey, I really enjoyed the most recent episode, talking about the one we did with Jared. Hearing the discussion about advocacy for all bodies and treating us fat folk with respect from a bariatric nurse was so helpful. I'd previously had respect for fat people in fat acceptance world and bariatric surgery in an anti-fat world. This has been a dilemma for me in the process of deciding on surgery. This episode helped me to investigate the fat acceptance part of me, to integrate the fat acceptance part of me with the having surgery part of me. Thank you." Now, I don't know about you, Dr. Alex, but I just thought, wow, for someone's mind to be changed like that.
Well, first of all, full credit to Jenny for having an open mind, willing to be changed.
Yes.
A lot of stuff you guys face and I face is closed minds unwilling to re-examine their preconceptions. So that's the first reason I reckon that's a cool message is Jenny has an open mind, and that puts me, like, to me, that puts her in sort of the top 1 or 2% of people, because a lot of people don't. So that's the first way cool part about that. I think the next is that, it thrills me, that idea that, someone would come to think, well, people who do bariatric surgery, metabolic surgery, as I'm more keen on calling it, because I guess when I do what I do with surgery or medications or diet and lifestyle stuff, whatever the person in front of me, whatever plan we come to together, I'm first and foremost in the anti-death camp. Like, I kind of want to keep people alive, because I think that's part of what I'm supposed to do as a doctor.
Yes.
I'm second in the anti-disease camp, whatever that may mean for the person in front of me.
Yeah.
I'm a little bit in the anti-ectopic adipose tissue camp. So in other words, getting as much as possible beyond those other two things, trying to get adipose tissue out of places where it will cause harm to health. So dealing with things like steatotic fatty liver disease, or steatotic liver disease, or often called fatty liver disease, and treating those things and getting fat out of the places it doesn't belong, and changing, body composition from visceral to less visceral, that sort of thing. Yeah. I think in terms of, anti-fat, well, yes, what I do is designed to do things to the human body that will result in less adipose tissue. But I put it to you that if the things that I did not change people's size one iota, and did not remove a single gram of adipose tissue, but still kept them alive longer and still got rid of disease, would I still do them? Hell's yes.
Yeah.
So I think,
amazing.
is that so that, to me, that's the hierarchy. And I think that what I'd also say, looking at that, is in terms of how bariatric surgery got into that place for Jenny. I think that's something that we as metabolic bariatric surgeons need to ask ourselves some hard questions, because of those four things: staying alive, less disease, body composition, people getting smaller. The operations all do those things regardless of how you talk about them and why patients choose to have them. But if we look at the messaging we put out as bariatric metabolic surgeons as a whole, how much of it is about life extension? How much of it is about disease reduction? How much of it is about body composition change? And how much of it is photos of reposted of belly shrinking, people in lycra, and sometimes even people that you can tell, like, there'll be models on websites that have, I can tell you right now, that person has never had an experience of obesity. That is someone who is not wearing many clothes and modeling a certain body type for a living. And so it's sort of this, I think bariatric and metabolic surgery as I said, a death reduction, disease reduction, pursuit thereof. And I worry that we sort of, often we see what we do, I'm starting to use the term cosmebolic surgery. They're the same operations, they have the same health benefit, but they're advertised with the advertising's all about body size and body image. And I want to be careful because I do support people getting loud and proud about what's happened to their body and feeling good and feeling able to do things that previously they wouldn't have been able to do. I don't want to have a go at people celebrating their achievements and experiences.
Yeah.
But where I do draw the line is I think that when that becomes, and let's face it sometimes becomes marketing, and so I've been very reticent to, I don't think I have reposted any of my patient stuff. I probably won't. What I would do, I guess, is I'm thinking if you sent me a before and after of your medication load, I'd love to post packets. If it's a little bit like, send me a before and after of your list of diagnosed diseases. That'd be cool. A before and after of activities you engage with pleasure and joy and without pain. I think all of those.
We would love that, guys. If you're listening to this podcast, send them in the comments.
Yeah, I would love to even talk about it.
Yeah.
And I guess my rationale for that is someone who engages with healthcare decision makers, at my local health service level, and I'm starting to do that more broadly, sort of nationwide. That's the sort of thing I can carry into an office full of healthcare decision makers, that it's that helps them understand what it is I do. When I go to a CEO of a hospital or a manager of a surgical department or heads of surgical units or heads of medical units or all those sorts of things, that's the kind of, I don't want to say advertising, but it is, but that's the kind of perception that really helps me get more people treated, independent of their, what am I trying to say? Independent of their financial situation and so that I kind of would love to see more of, and I'd certainly, I think it's hard. And to be fair, like, I'm going to say I think because of quite good regulation in Australia around what healthcare practitioners are allowed to and not allowed to say, Australia's actually pretty good in terms of this sort of stuff. And a lot of the companies you'll see that are most egregious in this in Australia are actually overseas companies advertising for surgical tourism.
Yep.
But I do, and look, at the end of the day, everyone's got a right to promote their business and their activities in whatever way they see fit, and everyone's got a right to post whatever they want to on social media. I'm not saying that. I'm not, but I just, if you I just think this could be more balanced. I think that I'd at least love to see equal spread across those four domains: staying alive, disease, body composition, looks.
Yeah.
I'd at least like to see equal. I'd prefer to see it, in a perfect world, I'd love to see it all about this and sort of, the weight stuff as a sideline. The other thing about that is that I think the other understanding that I'd offer around that is when I talk about obesity, and I know when you guys talk about obesity, we're not talking about bigness. And yes, technically, the so-called the diagnostic criteria for obesity in this country is a BMI. But when we talk about that, we are talking about one measure. The definition of obesity, the medical definition of obesity, is very different to that. And one of the things that I offer to sort of medical students is essentially what we've done is we've actually accidentally taken a screening tool and used it to define the disease. So if you had, for instance, if we look at another screening tool like the National Bowel Cancer Screening Test, like the poo test that comes in the mail and you see if you've got blood in your stool and you go, imagine if we define the presence or absence of bowel cancer based on that. Complete carnage. It'd be ridiculous. Imagine going and having your colon removed just because you had a positive poo test with the government. That's not the way it should happen. Likewise, a lot of people have bowel cancer that do not test positive on that. Yeah. You should still have your bowel cancer treatment if your poo test says there's no blood in your stool. And so we've made a separation. Now that's obviously an extreme example, but that's kind of what we've done here, and that's the reason why that's a bit. We've wrapped this up. Another one I guess from the general surgery world is we do screening mammogram. Now, something that might be abnormal. From that, what do? You don't just go and organise an operation. You sit down, you take your history, examine the patient, you do the pertinent investigations to diagnose and stage the disease. And in a lot of cases, those abnormalities on mammogram won't turn out to be a cancer. And in other cases, they will. But we don't define that. We don't then say the whole aim here is to remove the abnormality. The aim of bowel cancer treatment is not to have a normal fecal occult blood test next time you get tested by the government. No, the aim is to remove all diagnosable disease and extend your life as long as we can with the best possible functional outcomes. And so that's something that I hope we will see change soon. There is work going on, really important work, to give us a diagnostic criteria that matches the definition, right? And so the definition, exciting. And so the definition that's sort of fairly globally accepted is that it is or maybe not even progressive, but it is a chronic disease that is characterized, not caused by, but characterized by excess or abnormal adipose tissue. So it's not how much, so much as what is that adipose tissue doing that may impair health. And so we're now looking at, when we look at BMI, does it tell us the chronicity of what's going on? Maybe, maybe not. Does it tell us the excess adipose tissue? Kind of. It's kind of not bad for that, but it's not great. It doesn't tell us anything about the abnormal or damaging actions of that adipose tissue, which is much more important. Yep. And it doesn't tell us then anything about the degree to which, tells us very, very little about the degree to which that's going to harm people. And so when we talk about obesity as bigness, that becomes a problem because we've missed the point. Because when I look at it scientifically from a medical point of view, if I want to sit down and say, this person in front of me, how much danger are they in? Ultimately, that's what it comes down to is how scary is this? How likely is this to end that patient's life or significantly impact negatively on that patient's life? BMI is not a useful tool for that.
Agreed.
The amount of adipose tissue that a patient is carrying is not a useful tool for that at all, mathematically. Things that really help are the impact stuff. And all the stuff that you talked about before, Damo. When we look at what's going to help, presence or absence of disease, then if that disease is causing damage to other organs, even next level, that if there is a diagnosed disease that we know to be a complication of obesity and that is starting to damage other organs, that's really scary. BMI tells me nothing about that. Having a diagnosed disease, really worrying. I would be much worried if someone comes in with a normal BMI and type 2 diabetes. Don't even start me on that word normal, but comes in with a lower BMI and type 2 diabetes. That is much more scary from a medical, scientific, will this person die soon point of view than a high BMI and no evidence of metabolic disease. And
Wow.
so that's sort of where so when I'm talking about obesity, I'm talking about the biological, invisible pathology going on inside someone's body.
Yep.
I'm
Yep.
not talking about the bigness and size. And I think that's important when we have these conversations.
I agree.
And when I'm talking about obesity as the biology inside, and this is the actual point I was getting to like half an hour ago whenever we started this. Anyway, when I look at that biology, the amount of weight, the BMI, doesn't cause that. It is one outcome. So we have all these chemical, hormonal things going on inside the body, and there's lots of them. Yes, there's some GLP-1 stuff and some weight homeostasis stuff. There's also changes in the way we handle our energy substrates, so the way we handle cholesterol, the way we handle sugar. There's also biomechanical impacts, sleep apnea, joints, etc. There's so many different things that come out of that. One of them is a change in body composition. One of them is a change in body weight or an increase in BMI. And if you told me you're only allowed to know one thing, weight would not be top on the list, because from a statistical and scientific point of view, it's not the most important.
Wow.
And I think that's missing from this conversation is,
Yeah.
it is one of the outcomes, no doubt about it. Definitely is. Can be useful to screen for the disease, absolutely. But in terms of the most important, hell's no. Definitely 100% not. And so I think that's missing from a lot of the talk when we look at these things and the weight. And again, I mean, Dama, you said it, I think, before we were recording. I hate when people say weight loss surgery. It's just not, it's this sort of minor thing. Like it's kind of, to me, it's a little bit like saying a hip replacement is metal addition surgery.
Yeah.
Like, well, it happens, but, the presence or absence of that metal is far less important than how the patient's leg moves afterwards.
To me, it sort of makes it sound like it's a cosmetic thing. And so it's not really that serious. But, we're talking about cutting out 80% of someone's stomach or rerouting,
Things.
Their digestive tract. And, it's a bit more serious than just a weight loss surgery.
Yeah, and when we do all that stuff too, let's be clear that what we're really doing is rewiring the gut-brain axis. So we're talking about what we do to the stomach and what we do to the intestine is kind of like saying your car drives because it's got wheels and an engine. Like, well, yeah, but that's not really what's going on. There's the whole concept of internal combustion that I pretend to understand, but I don't. But that my brother had explained much better than me because he's actually mechanically minded. But what's going on there is yes, we've done those things, absolutely. But what the result of that is a radical change in the neural and hormonal responses to food and the way the body assesses and monitors and responds to its metabolic state. Yes, weight is part of those, but also the way it handles things like sugar and cholesterol and other things like that. And so when we do that, yes, what we're looking for is all of those other things, and some weight comes off. And I guess then the next question is, well, why do you still weigh people? The reason I still weigh people is that we do know that the percentage of weight loss from starting is actually kind of the most helpful weight-related marker for us. And it's almost like I tell medical students it's a little bit like with certain medications, we'll take a drug level and we'll check how much of that medication has got into their bloodstream. And so for me, it's sort of a measure of, have I delivered an effective intervention? It's not the same as, have I improved your health? Because I can deliver a very effective intervention. I can put you on, someone can come to, don't come to me if you've got a seizure disorder, but hypothetically speaking, if someone came to me with epilepsy, having frequent seizures, and I put them on a very effective anti-epileptic drug and they kept having seizures, yes, the drug level is great, but we still haven't actually dealt with the underlying medical problem. I'm not a seizure doctor. Don't come to me with seizures. But the point I actually wanted to make was it's not the same thing, but it does tell me, okay, have we delivered an effective intervention here? Yes or no? Then the second part of that equation is, did it have the desired effect? What goal were we out to achieve? Did this go ahead and achieve that? And you can see that in that equation, it's sort of a little check and balance thing, and that's probably where I think those of us who specialize in the treatment of this disease of obesity, this chronic disease of obesity, that's where we use weight. Is it's our, for want of a better term, it's our drug level. It's so when we are weighing and looking at change in body shape and size, it's really just that. And that's the other thing too. It's a measure of the intervention. It's not a measure of the patient.
Yep.
Excellent.
Right. So I'm not measuring, are you doing the right things and all this bollocks. I'm measuring, has the treatment that you and I hypothetically embarked on together, has this been effective? Has it been delivered effectively? And
so that's not saying that a patient is failing or having success with their surgery, is it? Because that's a term we hear so much, is I failed my sleeve or I failed my bypass. And, that it makes me upset to see people putting the blame on themselves again.
Again, a game that we play with obesity that we would not play anywhere else in medicine. So if I treat esophageal and gastric cancer. Could you imagine if I said, well, you failed your chemotherapy. The tumor didn't shrink. You failed that. No. We resect the entire disease. We're all happy with the histology. And then even with the best possible histology and outcomes and result, there is still a small chance of tumor coming back. Imagine that person comes back and I say, you failed surgery, your tumor came back, right? And so because that and the reason for this is that it just doesn't reflect medical reality. I'm not saying this because I'm a nice guy and I want people to like me. I think I'm a nice guy and I do want people to like me, but that's not what I say. Because the medical reality here is we know that with everything we've tried in obesity, there is a range of responses. Some people respond very well. Some people respond different. That's often why some people will have wonderful results from a particular diet that doesn't work for 99 other people. Some people will have spectacular results to a particular medication, and that for 30 and 40% of people don't get any response to. We are not dealing with one disease here. If we are dealing with one disease, it's like saying cancer. Right?
Yep.
This idea that, I've got cancer. Good, go to a cancer. No. What type is it? Where is it? And now even now we're even down to the point of what are the metabolic markers on that cancer and what's that going to say about our combination of treatment approaches and whether we use chemotherapy and in what order and all this sort of thing. Not only now is it, what is it? What type is it? Where is it? What's its metabolic profile? How does it respond to your initial treatment? All of these things are being taken into account. And when we sit down with something like cancer, I'm a trained cancer surgeon. But whenever I treat an esophagogastric cancer, I sit down in a room with a bunch of other trained surgeons in the same field and oncologists and radiation therapists and dietitians, and we all sit down together, and radiologists and pathologists, and we all sit down together and make sure that we are on agreement. And that is in a field where we are pretty advanced in our understanding. We have we have a pretty good idea of the biology behind this. It's getting better all the time, but we have a pretty good idea. We have a pretty good handle on predicting in advance what responses to our treatments will be. In obesity, we don't have that. We don't have a good handle. We're just scratching the surface on what's going on here with the biology. We've got some promising science. We're working better, miles away. We are nowhere on outcome prediction yet. We are nowhere there. We just not there. We just know everyone responds differently. On average, this is what happens, but that's it. We're miles behind. Yet we're in that failure narrative and putting it all back on patients. So really what we know is everyone responds differently to everything we do. And some people get a great response, some people don't. That's about the treatment. That's not about the person and their engagement with. And every time you look at this, it ends up being genetics are much more important than anything else. And so this is why it bothers me, is it's just not a reflection of medical reality. And so once you let go of that, this idea that, it's, and I'm even a little bit, they often hear that the surgery is a tool thing. Now, I occasionally use that, but what I mean by that is the surgery is a way to achieve other things that you want to achieve in your life. What I sometimes hear it talked about is, the surgery is only going to work as well as you use it. Well, that's not really true, frankly. Most of your response to surgery is going to be out of our control, both of us, genetic, really. And then you're going to be able to augment the response to surgery a little bit with diet and lifestyle stuff, just quietly, just as much as you get out of diet and lifestyle stuff before surgery. It's not the game changer that people, that's where, so these sorts of phrases, they all sound very innocent, but they underlie a bigger issue of putting personal blame for biology.
Yeah.
Mm.
And we don't control our metabolism. If we did, we would all die. It is so complex. If metabolism and weight homeostasis was under voluntary control, there is no way any of us would be able. That was all. It's all you could think about all day in and out. If you actually had to control your body weight, the levers that need to be pulled to maintain that stable weight, forget about it. You would not be able to think about anything else in your day. With the tight regulation on energy use over time, the tight regulation on energy input, output, all that stuff, it's incredibly complex, and we don't control it. So to pretend that we have voluntary control over that is really getting in the way of what's really going on. And so, yeah, that's the failure thing bothers me because it's just not true. It's just not real. It's just not meaningful. And yes, also, I mean, I don't make light of the fact that it also is quite stigmatizing and damaging to people, but it really pisses me off because it's just not true. It just doesn't reflect what we understand on this disease. We have, and so what I would offer instead is we have treatment responsive and treatment non-responsive disease. Some people might have a more or less diet responsive obesity. Some people will have a more or less GLP-1 responsive obesity. Some people have a more or less sleeve responsive obesity. Some people have a more or less, et cetera, et cetera. And when they don't respond, in any other disease, we call that treatment resistance disease. We know that we need to level up because this is a more aggressive, less responsive version of the disease. And that attitude works really well. Works really well.
I agree. And I hope that we can actually start to implement that type of language within our communities on social media. I think it would be very, very helpful.
Yeah. And I think that it feeds into this idea that one of the things you come up against is this idea that, people need to take more responsibility. This idea that if it's all on you, you'll be more motivated and work harder. And it's this sort of myth out there that the worse we treat people, the harder they try. Problem is, again, it's a real jerk attitude to have, but also it doesn't actually help. We know that blame, shame, it's all your fault is not helpful or motivating.
Yeah.
We also know that it's a lie. We know to the extent to which self-directed efforts work and don't work. We know that it's variable, but we know that overall, on average, it is about 3 to 5% weight loss at a year. Again, as a drug dose level, not as not as the primary aim. And most of that's back on average within 1 or 2 years. So if blame and shame were a medication, would you offer it at a 90-something% failure rate? And what I mean, that's what I'm saying. Like blame and shame, really ineffective as a tool. Also, from a psychological point of view, we know this. It's all your fault. We the psychological literature tells you that doesn't really help people live better lives. What I think we could offer instead of this responsibility narrative, it's all on you, is what I call agency, which is accepting where we're at and talking realistically and honestly about what options are, and then providing those options.
Yeah.
The difference there is it's not your fault, but there's something you can do about it. It's not your fault and there's something you can do about it is the whole reason I practice surgery. It's an extremely motivating place to be in. You guys, weight stigma is not your fault, but there's something you can do about it. That's an exciting thing. That's Mother Teresa, Gandhi, all this sort of stuff kind of came from, it's not my fault, but I can do something about it. We know psychologically is much more motivating and much more helpful to people. And it also, just coincidentally, really reflects reality. 40 to 70% of people's final body weight is based on their genetics. 30 to 60% of it is based on their environment. And most of that impact, most of this environment stuff happens before the fifth year of life, first 1,000 days. So most of this is trajectory set up from genetics and childhood. That, whichever way you slice and dice that, it doesn't leave a lot of room for this is all your fault as an adult. Sorry, that just doesn't reflect the reality of obesity as we understand it. So a lot of that doesn't, it doesn't compute. And so I think personally, how much is up to you as an adult? Maybe like 1 to 5% max.
Wow.
Fits well with what we know we get from self-directed, diet and lifestyle changes. So it seems like a sensible number. I certainly don't think it's more than 10% for just.
So what would you say to somebody that is wanting to access a metabolic procedure because their whole motivation is just to lose weight?
So I very rarely to never actually encounter that. I've treated a lot of patients now and don't think I've ever actually encountered that. One of the first things I'll ask in a consultation, it's probably the most important question, is what are our goals here?
Yep.
And what does success look like? And the reason I think they're the most important questions is that I know what I can do. And I need to know, does the person in front of me know what I can and can't do as a person that offers all forms of obesity treatment and doing them in combination. And often in that, a weight number comes up. And when I ask that patient, what does that weight number mean to you? That is often a floodgate opening moment. And in the few times that the number is really important, it is, and I can think of a case recently, it has been due to a childhood or adolescent trauma experience based around that. I have had situations where people describe not reaching a certain target and being ridiculed publicly in a group as part of a treatment for obesity. Like, that's the worst part. I have heard of instances of people in having to sort of record their weights publicly, even as part of a school maths exercise.
Yep.
And I don't believe for a second that the teacher doing that realised the profound impact and people needing to lie about a number or dodge that number because they knew what that would look like when their number was so much higher than everyone else's number and all those sorts of things. So really what we're looking at there is what that person really wants is closure on some childhood or adolescent trauma.
Yep.
And that's probably the most powerful rationale for an amount of weight loss. When we look behind that number, there, sometimes it is physical appearance related, but that number is really about what the physical appearance of that number would be. And then we get to have a good chat about the preference of body composition over, extreme weight loss, and the maintenance of muscle mass, and as it adds to, cosmetic appearance and body shape. Those are the only two scenarios where people are really onto a particular weight. Now,
can we just pause for a sec?
When we look at weight loss, when we look at the rationale behind it, we almost always find much more important things. And when you look at, those numbers are usually based around, well, I remember at that weight how well I could move. Yeah. I remember at that weight that I didn't have sleep apnea. I remember at that weight this, that, the other. And so, yeah, I do have people that come asking for, I just want to lose weight, and that's all. But when we look behind the curtains, there's often more important things. And I think if you don't look behind that, you potentially miss some really important things like trauma.
Yep.
And if I'll be honest with you, in terms of improving or contributing to the improvement in someone's quality of life, if I can help them manage personal trauma, that is probably worth as much or more than anything else I'm going to offer. You know, if I can look behind that weight number and find some, you know, and I'm not the person to help with that, but I work with some really good people who do work with that. And so then those are the patients that, I have the patients that have had really positive outcomes, but really, you know, come in and like, oh, isn't Kerry fantastic? I don't care about what I did. Like, really, like, you know, I'm sitting there, oh, that was a really tricky operation and I feel great and your outcomes are looking good and look, your diabetes gone away. But come on, compared to, and I don't think you ever heal childhood or adolescent trauma. I think that you find a way to manage it and
Yeah, I agree.
And work with it. That is so powerful and important. And so I think that, you know, for me, when people are looking at that yeah, that's something I can offer that is so much more than just, you know, the physical. And I think it's really important. So that's the thing, I guess, with the weight loss is that if someone really, really just wanted weight loss, yeah, I wouldn't mind that. I can help with that. I just haven't found it yet.
Yeah, I agree. I mean, I think that even for those people that say, oh, I just want to lose weight, there's always a reason behind it. There always is.
And those are valid and important. That's the other thing too, is that
right.
And again, from, you know, to put my medical doctor hat on, those are the things that often those things I can link much better to long-term health outcomes than the actual weight number. You know, things like improved mobility, exercise tolerance, cardiorespiratory reserve, remission of certain diseases. I can show you good evidence that they're really important in terms of how long you live and how well you're going to age. It's very hard to find accurate sort of outcomes of that based on weight alone.
So for people that are only just starting out, can you explain the different use the term adipose tissue? Why would we use that instead of, say, just fat?
I think in the medical world, the two are interchangeable. Fat is just a collection of cells. Fat, muscle, bone, brain. All I'm doing is describing a cell lineage. You know, blood. Unfortunately, that's not true in the broader world.
Yep.
And I think that, yeah, there's a lot of baggage there. And I think that the issue, maybe if I use adipose tissue, everyone knows I'm talking medically. And so we can get away from a bit of that. Having said that, I would love us to just reclaim the word fat as just a tissue, and that doesn't mean anything more. And you know, to do that, we need to all we need to do is just accept the realities of the determinants of body weight and size, genetic and environmental, minimum impact from deliberate decision making. The other thing we need to accept is that the amount that's there, the final weight and final amount of adipose tissue is kind of a little bit predetermined after treatment and depends on the impact of the treatment and the patient's starting weight. And where I'm getting to with that is when I look at someone, until I know where they've come from, I can't know whether they have done absolutely everything necessary to improve their health.
Yep.
So there's this idea that we should all be able to voluntarily get to a certain size. It's wrong. But the problem with that is that it takes just as roughly the same amount of impact of treatment to produce 20% weight loss between different individuals. The difference being is if you start at 100 kilos and get 20% weight loss and weigh 80 kilos now, and that puts you inside of this so-called normal body weight range, everyone's patting on your back. You've done it. You've achieved the goal. But if you start at 200 kilos and you it takes just the same amount of impact to get to 160 kilos. But at 160 kilos, the whole world is saying, you're halfway there.
Yeah.
which medically, scientifically is not true. That the amount of health improvement impact does relate to that percentage body weight. So 20% is 20%. 20% is awesome, by the way. Super effective amount of weight loss, and enough to radically change health and life expectancy. But yeah, and
I'll
so,
never forget, just after my sleeve, I'd lost about 60 kilos. So I was down to 150 kilos. And I went to diabetes clinic for a follow-up. And the nurse started talking to me about going on this weight loss plan and gave me all this literature, to
yeah,
to
and a
lose
generic
weight.
diet. Yeah,
Yeah, and I said, I've recently lost 60 kilos. She said, well, you'll need to lose more than that. And I walked out of there just absolutely feeling like shit. Whereas I'd walked in there all excited because, they're going to, back then still wanting approval from my GP and my diabetes educator and whoever else. And it was just met with, you need to lose more than that. It's like 60 kilos is a fuck ton of weight to lose.
yeah, absolutely. And the evidence on that is so for the diabetes thing, we know that, and this is for a lot of things, there's actually a tapering off of effect. So for most things, there's a minimum amount of weight you need before we can measure the response. For a lot of things, it's about 5%. For other things, it's about 10%, and for some, it's even 15%. Measurable impact start. Then there's a period where the measurable impact goes up pretty smoothly with the percentage of weight lost. But then we see a tapering off. And so diabetes is one in particular, is that when we look at the percentage weight loss from 5%, no, it doesn't really go away. That's why if people tell you, diet and lifestyle for long-term remission of diabetes is actually really hard to achieve, and it rarely is done. 5 to 10 to 15 to 20%, more and more people are going into remission with their diabetes. But at about 25, maybe 30%, that starts tapering off. And I can't show you any data that says that if you're at 30% weight loss and you go to 35, you're going to have a significantly higher chance of your diabetes going away. Certainly there's nothing to go from 30 to 35 to 40. And so that's not really understood, and the problem is when it's not understood by the people that should understand diabetes. That's a real concern. That's not something that, everyone needs to know. But if you're a diabetes person, that's kind of something you should know. That's your disease. And so, that gets me a bit grumpy as well, when you sort of when an endocrinologist sends me a patient who's doing spectacularly well and is above what I would consider, sort of that upper threshold of diabetes remission rate and wants, no, sorry, that's not achievable. And that scenario plays out with all sorts of things over and over again through all of medicine. Yeah, and again, built into this idea that everyone's carrying a certain amount of quote-unquote excess weight, and that until you get rid of all of that quote-unquote excess weight, and the way that's calculated is hugely problematic, but then you're not sort of fully healthy. Whereas the other problem, and I wouldn't object so much if it wasn't potentially harmful. So what we know from experience is that really restrictive dieting after metabolic surgery is a real worry when it comes to nutritional deficiencies, which can cause significant problems. Overall, in the normal circumstance, nutritional deficiencies after metabolic surgery are very rare. Meaningful nutrition, very rare. But restrictive dieting changes that equation. And so if someone's coming to you and you're doing great, then my concern as a surgeon is that can really upset the apple cart. Because if you go on, everything's good, all your bloods are good, right? You've got 30% total weight loss, massive life-changing impact on all your stuff, and you start getting generic advice and generic caloric restriction advice without the support of a really kick-ass dietitian, then you're in trouble, because you are going to get some of those problems that we see so rarely happen more and more. And my second concern with that is we're seeing this now in the medications population. So I'm seeing a not insignificant number of patients with iron deficiency, which in the setting of medications and restrictive dieting combined, and often unnecessarily and for minimum benefit. And so, yeah, so it is potentially harmful. The other places that I find it really harmful is that often people see a health practitioner with a bunch of success behind them. So we know weight's supposed to drift up over the adult years until about the age of 70. From from our 20s to our 70s, it goes up by 1 or 2% per year. That trajectory can be steeper in people with obesity. So maintaining a stable body weight isn't quote unquote failure. It's actually a sign that something is going against biology. If you're maintaining a stable weight throughout your 20s, 30s, 40s, 50s, you're actually bucking the trend. If you are maintaining a stable weight below where you started, some really good things are happening in your life in terms of weight maintenance. Now, horrible other things might be happening in your life. I'm not saying they're not, but things are happening that are good. And so I will often see people referred to me because they have quote unquote failed diet and lifestyle that may be sitting 10 or more % below their starting weight against all rational expectations. If I look at the scientific literature on this, and instead of, wow, congratulations, you're killing it, you are in the top 1% of achievement for self-directed diet and lifestyle change, they get, you've failed, you haven't done enough, you've got to try harder. The funny thing is, when I tell them they're doing so well, it doesn't demotivate them. It doesn't stop them from doing the things that they're doing. The real risk would be me, as Mr. Knowledgeable Obesity Expert, puts them on a different diet plan that doesn't work as well in their life, it doesn't work on for them, and suddenly they gain 5 kilos. And we often see this. Everything was going well, and then someone convinced me to try keto or paleo or low fat or low carb or something, or carnivore or whatever, and they put on weight. But this was a weight loss diet. How have I possibly put on weight? And what you don't realize is you were self-treating very effectively for a very long time, and then someone came in and gave you a worse plan. And so that's the other area where I think this is potentially harmful, and that's where I get really sort of a bit grumpy about it. Is that, yeah, it's a problem because it gets in the way of good treatment and makes people feel a failure when they shouldn't.
Amazing.
Yeah, it takes away their confidence.
Alex, thank you so much for joining us today. We've had
Absolute
an
pleasure.
amazing time, and I know we've got a few more podcasts that we're looking
Things
forward to doing
planned.
with you, and some plans.